Hello everyone, I hope you're all doing okay. This is our third video on the motor or the descending spinal pathways. Now we already have discussed the basic organization of the motor system as part of the video 1, and in video 2 we discussed the detailed anatomy of the corticospinal tract pathway along with the lesions along its course. So I would highly recommend that prior to listening to this video, you should listen to video 1 and 2 first. As part of this lecture now, we're going to do a quick recap of the corticospinal tract anatomy. Then we will apply the information learned about the corticospinal tract pathway clinically using a brief clinical scenario to help us localize neurological lesions. And then lastly, we'll practice a couple of SBA questions to further brush up our knowledge of corticospinal tract pathway anatomy. So let's just quickly summarize the corticospinal pathway. Now, the descending corticospinal pathway influences the voluntary skill movements of our distal musculature through the lateral corticospinal tract, whereas they influence the axial musculature to control the postural stability through the anterior corticospinal tract. Now, the upper motor neurons, as part of the corticospinal tract, they pop out from the cortex, they pass through the corona radiata, and then they descend down through the posterior limb of the internal capsule, which you can see over here. And we discussed this in detail in video 2, so you can always refer to video 2 to learn the anatomy of the corticospinal pathway in detail. Now, these descending pathways from the posterior limb of internal capsule, they're going to pass through the crus of the midbrain. Then they descend down through the ventral part of the pons as they traverse through the transverse pontocerebellar fibers. These fibers then further descend through the ventral part of the upper medulla, where they form a swelling which is known as the pyramid. Now from here onward, about 75 to 80% of the fibers, they cross over, they decussate, and then they become laterally situated, where they descend down in the medulla and in the spinal cord as the lateral corticospinal tract before they go down and synapse with the cell bodies of the lower motor neuron in the anterior horns of the spinal cord. The lower motor neurons are then eventually going to exit through the spinal nerve to influence the distal musculature, in this case, distal muscles of the limbs. The remaining 20 to 25% of the fibers which do not cross, they descend ipsilaterally on the same side close to the midline as the anterior corticospinal tract, which eventually get crossed at the respective spinal segment level, where after crossing they're going to synapse with the cell body of the lower motor neuron, either directly or indirectly through the gamma motor neurons, and then the lower motor neurons once again are going to exit through the spinal nerve at that respective spinal segment level to influence the muscles of the axial region to control the body posture. Now that we have done a quick review of the corticospinal pathway anatomy, how about if we apply this information clinically using a brief clinical scenario to help us localize neurological lesions? Right, so we've got a 60-year-old man with a history of smoking who presents to the clinic with a weakness of his right hand. Now, this is important to note because the left side of our brain usually controls the right side of the body and the right controls the left side. And it's because of the fact that most of the pathways, the descending as well as ascending pathways, they cross at certain point in the central nervous system. This crossing is known as the decussation. So this is an important pointer to help us potentially localize the neurological lesion. If the deficit, motor or sensory, is on the right side, then that could potentially mean that the lesion could be on the left side. It's not necessary though, but this is an important point to keep in mind. So this person has weakness in his right hand. He has also difficulty in conducting precise skilled movements with his hands, such as pen writing, typing, screwing a nut, and these are all fine skilled motor activities which are being usually controlled by the lateral corticospinal tract. So that also kind of raises a red flag that maybe the cortex and the lateral corticospinal tract at some point could be potentially involved. Right, so let's read the scenario further. Then this person also presents with weakness in his right leg as well, which means now almost the entire right side of the body, the upper as well as the lower limbs, are showing some signs of weakness or some kind of paralysis. Right, so next we do a clinical neurological examination, and the neurological examination shows that the person has weakness in his right hand grip as well, and the power has been reduced to 3/5. He has weakness in the dorsiflexion of his right leg as well, and therefore once again it shows that the motor weakness is elicited both in the upper as well as the lower limbs. And these clinical examination findings on motor examination, they are coinciding with the presentation in the history as well. The patient was also noticed to be having difficulty stabilizing his trunk and maintaining his posture. However, these are minimal, but that basically proposes that the anterior corticospinal tract to some extent might be involved as well. Although just keep in mind that the anterior corticospinal tract, unlike the lateral corticospinal tract, the anterior is so closely situated to the midline that there's a lot of overlap of the tracts across the midline. And so the deficit on one side is usually to some extent compensated by the tract from the other side, and so the neurological deficit doesn't really get clearly elicited, as is the case in lateral corticospinal tract, which is so far placed from the midline that we can actually see a weakness in one side of the body in the upper and the lower limbs, in the right upper and lower limbs, for instance, in this case, compared to the left side, which might be normal. Now, the careful examination further revealed in this scenario that his right lower facial muscles are weak as well and producing some kind of flattened nasolabial fold over here. So there's some facial involvement as well. There's weakness of the muscles of the face most probably, and we'll talk about that briefly as we discuss the clinical scenario. The sensory exam appears to be normal. Right, so this patient could have a lesion in the left cerebral cortex because the deficits are all on the right side, and the lesion might be involving the corticospinal tract at some level along its course in the central nervous system, and we'll find out where the lesion is situated in a moment. So let's discuss the scenario in a bit more detail now. So our patient has presented with weakness and motor impairment, such as the loss of precise scaled movements and weakness of the hand grip and some truncal instability as well, and the weakness is on the right side. Now, such motor functions are partly controlled by the corticospinal tract. The lateral corticospinal tract influences our appendicular musculature, and the anterior corticospinal tract affects our postural stability. Now, in order to be able to localize the lesion, we have to think about the lesion in a horizontal as well as in a vertical axis. And what do I mean by that? Now, for the horizontal axis, you have to figure out if the lesion is situated on the right side or on the left side of the midline inside the central nervous system. And for the vertical axis, you have to think where the lesion is situated from top down, extending anywhere from the cerebral cortex all the way down to the spinal cord inside the central nervous system. And you have to know that almost every spinal pathway, including the descending corticospinal tract, they are going to cross at a certain point inside the central nervous system. For instance, we can see the crossing over here. This is known as the decussation. And so when we're trying to localize the lesion in a vertical axis, we have to decide if the lesion is situated above the level of the decussation or if it is below the level of the decussation. Now, since the motor loss in this patient is seen in the limbs from neck below, including the arms as well as the legs, and the motor loss is elicited on the right side, therefore keeping this in perspective, the lesion could be either above the level of decussation or it could be below the level of decussation of corticospinal tract. In this illustration, which shows the corticospinal tract pathway over here, you can see the decussation is somewhere at this level over here, which is in the lower medulla. So the lesion could be either above the level of decussation anywhere along over here, or it could be below the level of decussation down below over here. Now, if the lesion is below the level of the decussation, then the lesion could be situated on the right side of the lateral spinal cord over here. If that is true, then the lesion would be situated ipsilateral to the motor deficit, which means that the motor deficit in this patient is on the right side and the lesion is going to be in the right lateral spinal cord as well, which means both the motor deficit and the lesion are ipsilateral to each other. If, however, the lesion is above the level of the decussation, so this is the decussation, it could be anywhere here in the central nervous system above the level of decussation, then the lesion could be situated anywhere in the left upper medulla, it could be in the left it could be in the left pons, it could be in the left midbrain, it could be in the left internal capsule, or it could be in the left cerebral cortex. If that is true, then that means that the lesion is contralateral to the motor deficit, which means that the motor deficit in this patient is on the right side, but the neurological lesion now is going to be higher up in the central nervous system on the left side, which means the lesion is contralateral to the motor deficit. Now, the patient in our clinical scenario has some facial weakness as well, and he's got facial weakness in the right lower face. So let's talk about the facial muscle innervation very briefly, although we'll talk about the innervation of the face in much more detail as part of our video on the cranial nerves covering the facial nerve. Now, as far as the facial muscle innervation is concerned, the upper motor neurons, they descend from the cortex, from the superolateral surface of the cortex, from this region over here where the facial muscles are represented as part of the homunculus. So the upper motor neurons basically descend from the cortex and decussate before synapsing with the cell bodies of the lower motor neurons inside the facial nucleus, inside the pons. The lower motor neurons then innervate the facial muscles on that side of the face. So if we see the lower motor neuron coming out on the right side of the pons over here inside the facial nerve, then these neurons are going to innervate the facial muscles on the right side of the face and vice versa. The decussation of the facial motor neuron pathway is happening inside the pons. Now, the facial weakness in the right lower part of the face could be explained by a lesion which could be either below the level of decussation of the facial motor neuron pathway, or it could be above the level of decussation of the facial motor neuron pathway, anywhere along this point over here. If the lesion is below the level of decussation, then that could potentially mean that the lesion is situated inside the lower pons, affecting the lower motor neuron pathway, which is emanating from the pons and traveling inside the facial nerve to innervate the muscles of the face on the right side. If, however, the lesion is above the level of decussation, then it could be situated anywhere along this pathway over here, which means that the lesion could be either in the left midbrain, in the left internal capsule, or in the left cerebral cortex, affecting the upper motor neuron inside the central nervous system. Now let's collate all this information together. Now, since the patient has motor loss on the right side of the face and on the right side of the body as well, involving both the right arm and the right leg, therefore the lesion has to be above the level of decussation of both the corticospinal tract and above the level of decussation of the facial motor neuron pathway as well. This condition can only be fulfilled by putting the lesion on the left side over here, either in the left midbrain or in the left internal capsule or in the left cerebral cortex. In this way, we will be on the left side and we will be above the level of decussation of both the corticospinal tract pathway and the facial motor neuron pathway, leading to a weakness on the right side, both in the face as well as in the right lower body. Now, had the lesion been on the left side inside the pons, then in that case, it still would have been above the level of decussation of the corticospinal tract, which was inside the lower medulla, but below the level of decussation of the facial motor neuron pathway. And then in this case, the motor loss in the body would still have been on the right side, involving both the arms and the legs on the right side. However, the facial muscle weakness would have been seen on the left side, because the lower motor neuron of the facial motor neuron pathway, which is innervating the facial muscles, is actually damaged on the left side in this case, leading to facial muscle weakness on the left side, which does not fit well with our clinical scenario. Similarly, if the lesion would have been on the right side in the pons, then it would have surely led to a facial weakness on the right side. However, since the lesion was on the right side, therefore, and above the level of decussation of the corticospinal tract, then the weakness in the body would have been elicited on the left side, which once again does not fit well with our clinical scenario. Therefore, in order to have the motor loss in the body as well as in the face on the right side, we need to have the lesion somewhere above the level of decussation of both the corticospinal tract as well as the medulla, which is achievable only if we think about the lesion being somewhere either in the left midbrain, in the crus of the midbrain, for instance, or in the left internal capsule, or in the left cerebral cortex. Now let's do a couple of SPA questions to further brush up our knowledge of the corticospinal motor neuron pathway. Now let's discuss a couple SPA questions to further brush up our knowledge of the corticospinal tract pathway. So here we've got a neurological deficit highlighted in red over here, and as a result of this deficit, what do you think, where would the weakness be elicited inside the body? Well, if you look over here, you're basically looking at a horizontal slice which has been taken through the midbrain, right? You can see the anterior aspect of the midbrain over here. These are the two crura, and this is the intrapeduncular fossa in the middle over here. And so the lesions seem to be situated in the right crus of the midbrain. So what do you think, where would the deficit be situated, and which option is going to be the correct answer? Well, option C is the correct answer. And why is that so? Well, because since the lesion is inside the right crus of the midbrain, so it is above the level of decussation of the corticospinal tract. The corticospinal tract was decussating in the lower medulla. And so as a result, because of the lesion being on the right side, the deficit would be on the left side of the body. And both the arms and the legs are going to be involved. And so the option C is going to be the correct answer. Now let's talk about another scenario over here. See, there's a 41-year-old woman who presents with weakness of the muscles of the lower part of the face on the left side. So there's facial weakness in the lower quadrant of the face, but on the left side, and there is some spastic paralysis of the left side of the body as well, involving both the arms as well as the legs. So we've got motor weakness in the face and in the arms and the legs, all being on the left side, and only the lower part of the face, the lower quadrant of the face, is affected. Now, which of the following areas could this lesion be related to? So what do you think, which option is going to be the correct answer here? Well, yep, the option E is the correct answer. And why is that the case? Well, let's just argue a little bit over here. Now see, since the lesion in the face as well as in the arms is present on the same side, that is on the left side, therefore the lesion must be situated above the decussation of both the facial motor neuron pathway as well as above the corticospinal tract pathway. And therefore this clearly eliminates option A and option B, because we know that the corticospinal tract pathway decussates inside the medulla and the facial motor neuron pathway is decussating inside the pons, and we need a lesion which is above the level of decussation of both these pathways. So the lesion has to be above the medulla and it has to be above the pons as well. Now we can easily eliminate option C, because we know that a lesion in the thalamus would lead to a sensory deficit. Here in this clinical scenario, there's only weakness elicited on neurological examination on the left side of the face and on the left side of the body. Now we're left with option D and option E. See, a lesion in the cerebral cortex as well can lead to this kind of a presentation. However, both the medial as well as the superolateral surfaces need to be involved, because our legs are represented on the medial surface of cerebral cortex, whereas the arms are represented on the superolateral surface, and both the surfaces need to be involved. However, in option D over here, the right medial surface of the cerebral cortex is involved, whereas the superolateral surface is spared. And since the patient has weakness of both the arms as well as the legs, so option D is not the correct answer, and hence we're left with only option E, which is the internal capsule on the right side, and that is the correct answer. Lastly, I would like to highlight an important point or concept regarding the upper motor neuron lesion of the corticospinal tract pathway. Now you might be wondering that if corticospinal tract pathway is excitatory on the lower motor neuron of the reflex arc, then why does an upper motor neuron lesion of the corticospinal tract would lead to hypertonia and hyperreflexia? I mean, if it is excitatory, then the loss of excitation should lead to hypotonia and hyporeflexia. Well, there's a reason for that, and let me explain that to you. You see, the relatively pure lesions of the corticospinal tract are very rare to happen. These can only be produced by a pure lesion either inside the pyramid, inside the medulla oblongata, or inside the primary motor area, which is the area for inside the cerebral cortex. This kind of lesions have been produced in the animals, such as in the cats and in primates, where predominantly a pure lesion inside the medullary pyramids, such as a pyridotomy, or a lesion induced inside the area 4 of the cerebral cortex, has led to an enduring flaccid paralysis along with hypotonia and hyporeflexia. And the reason here was because the excitatory influence of the corticospinal tract was gone. That led to hypotonia and hyperreflexia. This was also associated with the voluntary movement being stripped of its finer qualities, such as the fine coordinated movements of the hands and the fingers were gone, and that also signified that the corticospinal tract was involved, because we know that the lateral corticospinal tract is involved in controlling the fine coordinated movements of our appendicular musculature. This was also associated with a positive Babinski and loss of superficial reflexes. Now, since the pure corticospinal tract lesion does not produce hyperreflexia and hypertonia, there must be some other tract as well which gets involved along with the lesion of the corticospinal tract, and that might be the reason why a hyperreflexia and hypertonia is seen in a corticospinal tract lesion. So let me explain that to you. Now, if you look at this illustration over here, you can see that the corticospinal tract has been drawn over here. You can see the corticospinal tract originating from the cerebral cortex. It goes down along its usual pathway, it goes through the brainstem, and then it decussates inside the upper medulla, and then eventually synapses with the lower motor neuron of the reflex arc in the anterior horn of the spinal cord. But what you can see over here is that there's another spinal pathway which is running in very close approximation with the corticospinal tract pathway, and this is our corticoreticulospinal pathway. Now let's just explain this corticoreticulospinal pathway in a little bit more detail. So inside the brainstem, especially inside the medulla and inside the pons, we've got a meshwork of neurons situated over there, which is known as the reticular formation. We've got reticular formation inside the pons, and we've got reticular formation inside the medulla. The medullary reticular formation is inhibitory in nature, and it's a bit more laterally placed as well, which means that the spinal neurons, which means that the spinal pathways which originate from the medullary reticular formation going to the spinal cord, which are also known as the reticulospinal pathways, these are going to be inhibitory in nature. And so if there's a lesion to the reticulospinal pathways originating from the medullary reticular formation, that would lead to a loss of inhibition, leading to a hyperreflexia and hypertonic state of the spinal reflex. Now what you can see over here is that the cerebral cortex is giving off some corticoreticular neurons as well. These are coming from the area 6 of cerebral cortex, and these fibers are excitatory to the medullary reticular formation. So in other words, they augment the effect of the medullary reticular formation or the reticulospinal pathways. So in other words, what I mean to say is that the net effect of the corticoreticulospinal pathway is inhibition on the reflex arc. And so if there's a lesion of the corticoreticulospinal pathway, that would lead to a loss of inhibition, leading to hyperreflexia and hypertonia. And that is exactly what happens along with the lesion of corticospinal pathway as well. See, the corticoreticulospinal pathways are so tightly approximated, they are in so close approximation to the corticospinal pathway that a pure lesion of corticospinal pathway is just very rare to happen, except for a lesion which happens inside the area 4 or maybe a medullary peridotomy. However, clinically speaking, these things are rare to happen. So whenever there is a lesion of the corticospinal tract, the corticoreticulospinal pathways get affected as well. And so the loss of inhibition is because of the lesion of corticoreticulospinal pathway, leading to hypertonia and hyperreflexia, whereas the voluntary movement being stripped of its finer qualities, that is basically a feature of the corticospinal tract pathway. And so the lesion of both the tracts leads to this mixed combination where we see loss of fine coordinated movements of our appendicular musculature, such as the hands and the fingers, and the loss of inhibition leading to hypertonia and hyperreflexia is because of the lesion of the corticoreticulospinal pathway. Right, so in this lecture, we basically did a bit of a recap of the corticospinal tract anatomy. We discussed the corticospinal tract in a little bit more detail in more clinical scenario-based fashion. We discussed how to localize the neurological lesion below and above the decussation on the right and left side inside the central nervous system based on our knowledge of the neuroanatomy of the corticospinal tract. And then we practiced a couple SBA questions as well. Thank you very much for listening. I hope you benefited from this lecture. If yes, then please do like the video and don't forget to subscribe the channel. Bye for now.